Happy Nurses Week to all the nurses and future nurses listening. To celebrate, I'm having a 20% off sale on Study Sesh. This is my private podcast that features over 140 episodes to help you study on the go. Formats include pod quizzes, power hour deep dives, drills, and case studies. If you're tired of sitting at your desk or staring at a screen, but still want to review for nursing school, it's time to check out Study Sesh. Go to straightanursingstudent.com and click on Courses in that top menu bar. That's straightanursingstudent.com and click on Courses in the menu bar. See you there. Well, hello there. I'm Nurse Mo, and this is the Straight A Nursing Podcast, where I teach concepts and share tips on how to thrive in nursing school and at the bedside. This is a very special episode. It is part of a nursing podcast, PodCrawl, to celebrate Nurses Week and increase awareness about the different types of shock. So I am going to be talking to you about distributive shock, and you can find episodes about hypovolemic shock, obstructive shock, and cardiogenic shock in these podcasts. Are you ready? You're going to want to listen to the Q Word podcast and the Up My Nursing Game podcast, as well as the Nurse Dose podcast, and the Rapid Response RN podcast, and the Critical Care Scenarios podcast. So I will put a link to all of those in the episode notes so that you can check them out and learn about all the different types of shock as we join together as nursing podcasters to celebrate Nurses Week and give you some education on a very interesting topic. So before we hop into our episode, and this is going to be a big one, so get comfortable, let's take a quick minute for a listener shout out. And this shout out goes out to Sarah. Hey, Sarah. And Sarah says this: I'm heading to nursing school soon and have been doing prerequisite courses and listening to a couple of these episodes each week while commuting or walking. Nurse Mo is like having a cool aunt with ICU nursing experience, always ready to help you learn. She is great at explaining things in a simple, straightforward, and memorable way, from disease processes to medications to key professional and communication skills for bedside nurses. I already feel more confident about this career change thanks to her podcasts and her website. Well, Sarah, thank you so very much. And I'm just thrilled that the podcast is helping you as you go along this journey to become and be an awesome nurse. And I really hope I explained distributive shock in a simple and straightforward and memorable way for you and anyone, of course, who is listening. So the first thing I want to do is define shock, especially if you're new, you may not really be familiar with this concept yet, and I want you to get as much out of this episode as possible. So shock is defined as a state of cellular and tissue hypoxia. So basically, the cells and the tissues are not getting enough oxygen, and this is due to reduced oxygen delivery, increased oxygen consumption at the cells and the tissues, inadequate utilization of oxygen, or a combination of any of these. And there are four main types of shock. There's hypovolemic shock, cardiogenic shock, obstructive shock, and distributive shock. And in this lesson, this episode, I'm going to provide an overview of distributive shock. And in order to have some basic knowledge of shock, you have to have some basic knowledge of hemodynamics. And I understand people listening to this podcast are from a wide range of levels of experience. You might be someone thinking about going into nursing school. You might be a first semester student or a student in your advanced med surg class. You might be a nurse who's been working at the bedside for a while. So we're all at varying degrees of understanding. So I'm going to keep this as simple as I can so that everyone can understand it, because you are absolutely capable of understanding distributive shock and hemodynamics. So if we look at hemodynamics in very, very simple terms, thinking about it as three key components: volume, the blood vessels, and the heart. So that's three key components of hemodynamics. So volume is the amount of blood that's inside the blood vessels. The blood vessels is another component, and we also sometimes call this the vasculature, and you may hear me refer to it as the vasculature in this episode. So think of the blood vessels as a bucket, and this bucket holds all the blood volume in the body. And then we have that third component, which is the heart. And this is the pump that's forcefully pushing blood through the blood vessels. So that is hemodynamics in very simple terms, the key components of hemodynamics. And then we need to talk a little bit now about the factors that affect blood pressure. So before we can really get into distributive shock, we have to understand these factors that contribute to blood pressure. And ultimately, blood pressure leads to tissue perfusion. And there are two key contributors to blood pressure. One is cardiac output, and another is systemic vascular resistance, or SVR. So let's first take a quick look at cardiac output. And if you've been through a physiology class, you already know this. So even if you're not even in nursing school yet, and you're doing your prerequisites and you've learned physiology, you understand this concept. So cardiac output is affected by heart rate and stroke volume. Basically, cardiac output is equal to heart rate times stroke volume. So let's look at stroke volume. Stroke volume is affected by three things: preload, afterload, and contractility. So preload, that is the amount of stretch at the end of diastole. So we have systole and diastole. So the amount of stretch at the end of diastole as the heart is filling is preload. And preload is highly dependent on blood volume. The more volume we have, the more we fill the ventricles, the more stretch we have. And the more stretch we have, the more contractility we get. And with that, we get higher cardiac output. Think of taking a rubber band and you're trying to shoot it across the room at somebody, right? Your brother's across the room. You want to hit him with a rubber band. So if you pull back just a little bit on that rubber band, how far is it going to go? It's not going to fly across the room and hit your brother like you want it to, right? But if you pull way back on that rubber band and let it go, that thing's going to fly, right? Because you had more stretch. And with more stretch, you had more contractility, and bam, higher cardiac output. So that's preload. Afterload is the force the ventricles must work against. So if you've got tightly constricted vessels, this is going to increase afterload, and that causes the heart to have to work harder. And then contractility is how effectively the muscle fibers of the heart contract. Stronger contractions create greater stroke volume, and with that comes increased cardiac output. So again, cardiac output is equal to heart rate times stroke volume, and stroke volume is affected by preload, afterload, and contractility. And then the other key contributor to blood pressure that I mentioned was systemic vascular resistance, or SVR. And SVR is affected by three things. One is the length of the vascular bed. We really can't do much about that. Another is the viscosity of the blood. We can kind of do something about that. Let's say, for example, you have a patient with polycythemia. Their blood is very thick because they haven't been, taking any medication maybe for it. And now they're having decreased perfusion because the viscosity of the blood is too thick. What if we give them some fluid and now the viscosity of the blood isn't quite as thick? That would decrease SVR. And then the other thing that SVR is affected by is vascular tone. So of these three things, vascular tone is the most variable. It's the most dynamic. Moment to moment, it can change. And when vessels dilate, SVR goes down. And when the vessels constrict, SVR goes up. So as we go through this discussion about distributive shock, you'll see this in action. And if you're not quite connecting the dots yet, I hope that you will by the time we get through this episode. So now let's dive into the basics of distributive shock, and then we're going to go through the different types of distributive shock, of which there are 3 different types. So as for the basics, distributive shock is a type of shock in which systemic vasodilation leads to hypotension and decreased tissue perfusion. So I'll say that again. In distributive shock, we have systemic vasodilation, we get hypotension, and because the blood pressure is so low, we don't get good tissue perfusion. So in other words, if you think of the blood vessels as a bucket, the bucket is too big. When we say vasodilate, the blood vessels are getting bigger. The bucket got too big for the amount of volume that is circulating around. Remember, when blood vessels constrict, what happens to blood pressure? Blood pressure goes up. And if blood pressure is improved, tissue perfusion is improved. The tissues are getting the oxygen they need. When vessels dilate, blood pressure drops. And if it drops too much, oxygen delivery to the tissues is therefore compromised. In distributive shock, the vessels are dilated, so blood pressure is low and tissue perfusion is inadequate. So that is the basic overview of distributive shock. Now let's dive into the 3 different types: anaphylactic, neurogenic, and septic shock. We'll start with anaphylactic shock. So anaphylactic shock results from a severe hypersensitivity reaction. Think of a person who has a peanut allergy or who has an anaphylactic reaction to an antibiotic such as penicillin. So when this individual is exposed to the allergen, the body has this huge, overwhelming response, which leads to systemic vasodilation and capillary permeability, both of which contribute to that shock state. So let's talk through the pathophysiology. First, we have the individual being exposed to the allergen, and biochemical mediators are then released, which cause systemic vasodilation and that capillary permeability I just mentioned. So vasodilation increases the size of the bucket. Remember, the vasculature is like a bucket, and we've made the bucket bigger. So now the bucket is too large for the amount of blood volume that is present, and hypotension results. And then capillary permeability allows fluid to leak into the vascular space. And what do you think that does to volume? It decreases it. So now we have an even greater mismatch between how much volume we have in our bucket and the size of our bucket. So that's basically a mismatch between volume and vascular tone. The fluid can also leak into the interstitial space of the airway, and this causes angioedema and airway compromise. When you think about anaphylactic shock, I want you to understand how quickly all of this can happen. Up to 35% of intravascular volume can leak into the extravascular space within minutes, which means this patient can lose a lot of volume very, very quickly and decompensate very, very quickly. So they have this decreased volume, and that leads to decreased venous return and decreased preload. And all of this leads to decreased stroke volume and decreased cardiac output. And when we have decreased cardiac output, we're further contributing to that hypotension and that inadequate tissue perfusion, which leads to impaired cellular metabolism and that shock state. The cells are not getting enough oxygen. So in addition to all these issues with blood pressure and possibly angioedema, anaphylaxis can cause some other problems as well. This includes excessive mucus production. This includes bronchoconstriction and coronary vasoconstriction. So now we have hypotension, severe hypotension, we have airway compromise, and cardiac dysfunction as well. So death from anaphylaxis can occur due to cardiovascular collapse, airway obstruction, or in a lot of cases, both. So what are the signs and symptoms of anaphylaxis? Because obviously, if someone can lose 35% of their intravascular volume within minutes and have angioedema and bronchoconstriction and all these problems, we obviously want to notice anaphylaxis very quickly so that we can act quickly. So one of the things about anaphylaxis is we tend to think of this as something that happens almost immediately when exposed to an allergen. And in some cases, the symptoms can come on very quickly. But in other cases, it could take up to an hour for the individual to have symptoms, which is why, let's say you're giving a patient an antibiotic they've never had before, you really want to keep a close eye on them, not just for the first couple minutes, but really throughout that infusion and for, up to an hour afterwards. So some signs of anaphylaxis include erythema, urticaria, and pruritus. And these are often present prior to other signs and symptoms. Not always, but they can be present before other symptoms manifest. Angioedema is another one that can occur early, and this can definitely affect the airway. We can also get angioedema in the GI tract. So airway involvement causes the patient to feel restless, apprehensive because they're hypoxic, basically. They're not able to get good breath. They can feel that fullness in their throat. They may be coughing. They may have a hoarse voice. You may hear inspiratory stridor, which is just one of the scariest sounds that you can possibly hear. They may be wheezing. Again, they may have that sensation of fullness in their throat, have difficulty swallowing. So maybe they're drooling all of a sudden. They could have shortness of breath, which is very likely, and feelings of chest tightness. And then angioedema in the GI tract can cause abdominal pain, vomiting, and diarrhea. So let's say you give a patient an antibiotic and you educate them as you do when you give them a medication. This could cause some diarrhea. And then within an hour of getting the medication, they're having diarrhea. Well, sure, that could be a side effect of the medication, but look for other signs and symptoms that they could be having an anaphylactic reaction. Other signs and symptoms of anaphylaxis include hypotension and tachycardia as this reaction progresses. You may have flat jugular veins due to decreased right ventricular volumes. Remember, preload is way down. The patient may have altered level of consciousness as tissue perfusion suffers, and brain is tissue, so the brain's not getting enough oxygen, they're going to be altered. And then a non-invasive hemodynamic assessment would show reduced cardiac index and reduced cardiac output, as well as decreased systemic vascular resistance. So those would be the key signs and symptoms of anaphylaxis. So how are we going to treat this? So let's look at each of the problems associated with anaphylaxis and what we can do to address them. I always say nursing is about seeing problems and fixing problems and anticipating problems and avoiding problems. So what's a problem with anaphylaxis? Well, one of those is exposure to the allergen. The solution is to stop the exposure immediately if we can. If the patient is getting an antibiotic, we stop the antibiotic. If they're getting blood, we stop the blood transfusion. We're going to stop exposure immediately. In some cases, they already ate the peanut or they already got stung by the bee and we can't do anything about it. But if you can, stop the exposure. Another problem is the disastrous effects of biochemical mediators. And the solution here is epinephrine. Epinephrine is going to stop the further release of these mediators. And we'll talk a little bit more about epinephrine in just a moment. Another problem with anaphylaxis is airway obstruction. Very serious problem. So what are we going to do? We're going to give oxygen to the patient. They may need to be intubated and put on a mechanical ventilator. They are going to get epinephrine. And what does epinephrine do? We already gave it to stop the further release of the biochemical mediators. Well, it's also going to cause bronchodilation, which opens up the airways. We can also give albuterol to cause bronchodilation and open up the airways. What's another problem with anaphylaxis? How about inadequate tissue perfusion due to that vasodilation? What's the solution here? Epinephrine again, epinephrine to the rescue. It's going to cause vasoconstriction, which increases blood pressure and improves oxygen delivery to the tissues. Another problem with anaphylaxis is deficient fluid volume due to that vascular permeability. We're basically third spacing out our fluids. So what's our solution? We're going to give some IV fluids. So normal saline is the preferred solution in anaphylaxis because lactated ringers can potentially contribute to metabolic alkalosis. But if the patient needs large volumes, normal saline in large volumes can cause hyperchloremic metabolic acidosis. So in a lot of cases, you may see a combination of normal saline and lactated ringers utilized. Another problem in anaphylaxis is myocardial depression due to coronary vasoconstriction. So the solution here might be an inotrope such as dopamine. How about this problem? The patient is taking a beta blocker and not responding adequately to epinephrine. Think about it. You give them epinephrine, but they're taking a medication designed to block the effects of a medication like epinephrine, right? So glucagon may be utilized because it has some inotropic and chronotropic effects. Note that the rapid infusion of glucagon can cause vomiting in your patient, so you want to make sure you protect their airway. What about the problem of itching and hives? The solution is often diphenhydramine, which is Benadryl, and this blocks the histamine response. Note, though, however, that it can cause sedation. If you've ever taken Benadryl to help you sleep, you know that that's definitely true. So if this is a concern, cetirizine IV, which is another antihistamine, may be utilized. And then there's also another problem, which is a risk for a biphasic reaction, which is where we have some resolution of symptoms, but they return later after treatment. And in some cases, glucocorticoids may be utilized, like methylprednisolone, to reduce the risk for that biphasic reaction or the return of symptoms. So we've talked about epinephrine a lot. Like that is a key treatment in anaphylaxis. Very important safety note about epinephrine is that it comes in 2 concentrations, and which one is utilized depends on the route of administration. So IM, intramuscular epinephrine, is in the concentration of 1 to 1,000. So it's more concentrated. IV epinephrine is in a concentration of 1 to 10,000. So it's more dilute. Okay, so for IM epinephrine, more concentrated. Think of muscles as being hard and strong and concentrated. That's when you give the 1 to 1,000. And for the blood vessels, we give a more dilute version because it's going to go straight to the heart. So that's the 1 to 10,000 concentration. Note that some patients may need epinephrine as a continuous infusion. If they're not responsive to repeat boluses of epinephrine or aggressive fluid resuscitation, that patient may be on a continuous epinephrine drip. All right, so here's your TLDR for anaphylactic shock. It is in response to an allergen. There is systemic vasodilation and hypotension, and loss of fluids into the interstitial space due to capillary permeability. There is airway obstruction, and the key treatments are airway protection, fluids, and epinephrine. So that is your quick overview of anaphylactic shock, which is just one type of distributive shock. Next, we'll dive into neurogenic shock. But before we do that, let's take a quick minute for a bit of a break. And then when we come back, we'll dive into neurogenic shock.
I'm Jane Perlez, longtime foreign correspondent and former Beijing bureau chief for the New York Times. I've been a foreign correspondent in lots of places: Somalia, Indonesia, Pakistan, but nowhere as important to the world as China.
I mean, China is not dropping anti-democratic paratroopers into Montana. But of course, we did see things like the weather balloon/spy balloon riveting the whole country for a week.
This is Face Off, an 8-part series in which we'll take you behind the scenes to key moments in the tumultuous US-China relationship. We'll speak with a diplomat, a spy, a tech reporter, a US admiral, even Yo-Yo Ma. Plus, my pal and noted China historian Rana Mitter joins the conversation. We'll look at what's driving the two nations apart and explore whether anything can help bring them back together. Face Off launches April 9th.
So neurogenic shock is, of course, another type of distributive shock. And this subtype is most commonly associated with spinal cord injury. And it involves a loss of sympathetic tone and a disrupted sympathetic nervous system. So let's break down the key parts of the pathophysiology of neurogenic shock. So we have a spinal cord injury, which causes the transmission of impulses to be interrupted. With that, we have loss of sympathetic tone, and this causes systemic vasodilation. So on the arterial side, this leads to decreased systemic vascular resistance, hypotension, and poor tissue perfusion. On the venous side, this leads to pooling of blood and decreased venous return. So if we have decreased venous return, this leads to decreased preload, which leads to decreased stroke volume and decreased cardiac output, just like we talked about in anaphylactic shock. Decreased cardiac output is going to further contribute to hypotension and that inadequate tissue perfusion. Inadequate tissue perfusion leads to impaired cellular metabolism. Loss of sympathetic tone also inhibits the baroreceptor response, and the result is bradycardia. This reduces cardiac output even more, and tissue perfusion continues to suffer. Loss of sympathetic tone also leads to disrupted thermoregulation, and the patient becomes poikilothermic. So as a result, they are unable to regulate their own body temperature and must rely on the temperature of the environment. So let's look at the signs and symptoms of neurogenic shock. And it's really important to understand that neurogenic shock may not happen at the time of the injury. In some cases, it can develop hours or even days later due to secondary spinal cord injury related to edema and hemorrhagic necrosis of the gray matter at the site of the injury. So let's say you're working in a trauma unit and a patient comes in, they've had a spinal cord injury, and now it's the next day, And you might think, oh, well, they're not at risk for neurogenic shock. Yes, they actually still are because of that secondary spinal cord injury. So the signs of neurogenic shock are hypotension and bradycardia. Now, you're probably thinking, wait a minute, that's weird. Usually, hypotension causes tachycardia. And that's how you can kind of recognize that it's neurogenic shock. It is the only type of shock with hypotension and bradycardia. The patient may feel warm and dry on the extremities due to pooling of blood and vasodilation, but they'll also be hypothermic because they're losing heat in the periphery and they don't have that thermoregulation. And then non-invasive hemodynamic monitoring shows reduced cardiac index, reduced cardiac output, and decreased systemic vascular resistance. So now let's find our problems and fix them. How is neurogenic shock treated? So one problem is that there is risk for further injury. So a key solution here is to immobilize the spine. We don't want to cause further injury. Another problem with neurogenic shock is relative hypovolemia due to vasodilation. So when we say hypovolemia is relative, what we're basically saying is the bucket is too big for the amount of fluid that is present. When the bucket gets too large, then we have hypovolemia because there's not enough fluid to fill up the big bucket. But if there was no vasodilation and the bucket were normal sized, the patient may be euvolemic or have a normal fluid volume status. So when we say it's relative, we're saying they're hypovolemic relative to the size of the blood vessels right now. The blood vessels are dilated, the bucket is too big. So what is the treatment for that? The treatment for that is to fill up the bucket. We want to improve the fluid volume status, and this will help improve preload and ultimately improve cardiac output. Another problem, though, is hypotension because of the vasodilation. So how do we address that? In addition to giving the fluids, we need to address the vasodilation. So we give vasopressors such as norepinephrine, and norepinephrine causes vasoconstriction, which increases blood pressure. Another key problem with neurogenic shock that we don't see in other shock states is bradycardia. And the solution is to address the bradycardia. Can we get the heart rate up? Maybe the patient gets a medication like atropine. Maybe they get external pacing, and this is going to increase cardiac output. In some cases, a medication like dopamine may be utilized. Another problem with neurogenic shock is hypothermia. We want to maintain a warm environment and warming devices to keep them at a good body temperature. And then another problem is risk for deep vein thrombosis due to venous pooling. So the solution here would be SCUDs or sequential compression devices and passive range of motion to promote venous return. And the patient will also have anticoagulants prescribed to prevent the formation of blood clots. So the TLDR for neurogenic shock is that it is usually associated with spinal cord injury. It involves systemic vasodilation and hypotension. It involves bradycardia, which sets it apart from other shock states. The patient could have warm, dry skin and poikilothermia or hypothermia. If the environment is cold, they're going to be cold. And key treatments are fluids, vasopressors, atropine, or pacing. Okay, we've made it through 2 kinds of distributive shock. Now we're going to dive into the meatiest type of distributive shock, which is septic shock. And septic shock is the most common type of distributive shock that you'll see in the inpatient setting. And it results from an overwhelming and dysregulated inflammatory response to infection. And note that the sepsis response is going to range in severity. So not all patients who have sepsis will go into septic shock. It is, however, a leading cause of death in non-cardiac ICUs and has a mortality rate of 1 in 3. So first, let's review those levels of severity of sepsis, or that sepsis continuum. So first we have SIRS, or Systemic Inflammatory Response Syndrome. It's important to note that not all patients with SIRS have sepsis, but all patients with sepsis had SIRS at the very beginning. So SIRS is an exaggerated response to some kind of stressor. This stressor could be surgery, it could be acute inflammation, it could be tissue ischemia, it could be cancer. To meet SIRS criteria, the patient must have 2 of the following. So they must have a temperature above 38 degrees or below 36 degrees. So that's 1, a high or a low temp. A heart rate above 90 beats per minute. Now we know that tachycardia technically is above 100 beats per minute, but it's actually going to be a much lower threshold when we're looking at SIRS. It's above 90 beats per minute. A respiratory rate above 20 breaths per minute. That's why you have to count respirations and not just pretend you counted and document 16 breaths per minute. You have to actually count them. So a respiratory rate above 20 or a PaCO2 below 32, and that would indicate hyperventilation. And then the other criteria is white blood cells above 12,000 or below 4,000 or greater than 10% bands. So 2 of those, if they have 2 of those, they meet criteria for SIRS. Doesn't mean they're septic, it means they have SIRS. Now, in order to have a sepsis screen be positive, the patient has SIRS criteria that has been met, plus suspected or confirmed infection. So if I've got a patient who meets 2 criteria for SIRS and they've got cloudy urine, I may not have confirmation that they have a UTI, but that's suspected. Now they screen positive for sepsis. Next is severe sepsis. So this is sepsis that has resulted in organ dysfunction. And this can include things like increased oxygen requirements. Your patient was on room air this morning. Now they're on 4 liters nasal cannula. What's going on? They have increased oxygen requirements. They could have coagulation abnormalities, such as platelets that drop below 100,000 or an INR that's above 1.5. They could have elevated bilirubin, which would show liver involvement, decreased urine output, or elevated creatinine. Another key indicator of severe sepsis is a lactate above 2. And then septic shock is present when we have low blood pressure or hypotension that is refractory to fluid resuscitation, which means somebody was hypotensive with sepsis. We gave them fluids. They were still hypotensive. Now they have septic shock. A patient will also meet criteria for septic shock if they have a lactate that is greater than 4. So if they have a lactate that's that high, even if they're not hypotensive for some reason, they're still in septic shock and need aggressive treatment. So in addition to being the most common type of shock that you'll see, guess what? It's also the most complex. For the purposes of this review, I'll keep it as simple as possible, okay? So when we're looking at sepsis triggers, who are we going to be highly suspicious about sepsis on? The most common triggers for sepsis are pneumonia, urinary tract infections, and infections of the GI tract. And sure, we tend to look at these as localized infections. We have a urinary tract infection and we think, well, that's the urinary tract that's infected. It can actually trigger the body's immune response in this overblown, dysregulated way, leading to that systemic reaction that if we don't treat it, or if we don't treat it adequately or quickly enough, can cascade into that overwhelming systemic response. And that once it gets really rolling, it's very, very difficult to treat. So in a normal inflammatory response, there's this balance between pro-inflammation and anti-inflammation. And so that means in most cases, the inflammatory response is mediated. The infection is controlled and the infected tissue heals and your patient gets better. But in sepsis, the pro-inflammatory mediators are way out of balance with those anti-inflammatory mediators. And guess what wins? Inflammation wins. The end result is hypoperfusion, tissue ischemia, and multi-organ dysfunction syndrome, or MODS, or MODS. So let's talk through the pathophysiology of septic shock in its absolute most basic terms. If you are looking for much more in depth on this, you can 100% find it. It gets real complicated, real fast. We're going to keep it as basic as we can. So in sepsis, a pathogen invades the body, and this activates the body's immune response. In most cases, this is a bacterial infection, again, of the urinary tract, of the lungs, the soft tissues, and the abdominal organs. Then we have mediators, cytokines, and pathogen-related molecules that are released, and this causes coagulation and complement cascades to be activated. And cytokines initiate the overwhelming systemic inflammatory response. So the short version of this is a pathogen invades the body and the body reacts in a way overblown way, and we have an overwhelming systemic inflammatory response. Something else that can happen when I mentioned coagulation being affected, we get microvascular thrombosis, and this occurs system-wide, and it's due to the activation of the coagulation cascade. In addition, anti-clotting mechanisms are disrupted, and this leads to DIC. And then another part of the pathophysiology of septic shock has to do with endothelial damage. So endothelial damage and the activation of inflammatory cytokines lead to massive vasodilation. You're starting to see some similarities, right, between these different types of distributive shock. They all have vasodilation in common. So what does this mean for the bucket? The bucket is now too large for the amount of fluid inside. This is that relative hypovolemia. So when these vessels dilate, the blood pressure goes down, and the result is impaired tissue perfusion. Now with sepsis, we also have increased capillary permeability, just like we had in anaphylaxis. And what this does is it allows fluid to leak into the interstitial space, causing even more hypovolemia. So this hypovolemia leads to decreased venous return, decreased preload, decreased cardiac output, hypotension, and even more impaired tissue perfusion. So the central nervous system responds to this invading pathogen by stimulating the sympathetic nervous system, and this causes a hypermetabolic state. So in this state, oxygen demands increase, and we already have impaired tissue perfusion. So what do you think's happening at the cell level? They get even more hypoxic. And without adequate oxygen, cells have to rely on anaerobic metabolism. And if you remember your Krebs cycle, you know that this results in the buildup of lactic acid. And this cellular hypoxia leads to tissue ischemia, multiple organ dysfunction syndrome, organ failure, and death. So obviously, septic shock is really, really bad. The mortality is very high. And again, once this cascade starts happening, it's very difficult to treat. That's why we really want to catch sepsis as early as possible. That's why we do sepsis screening routinely in our patients. But if a patient does progress to septic shock, what are we going to see as the signs and symptoms? So in that hyperdynamic state where shock is initially compensated, the patient may have a normal blood pressure, but they could show other signs such as warm extremities, a very brisk capillary refill, like less than 1 second brisk, and bounding pulses. Now, obviously, the body cannot maintain this hyperdynamic state for long, and decompensation will follow if aggressive treatment is not initiated. So that could be some signs that you might see in that hyperdynamic state. You're also going to see things like tachypnea and increased oxygen requirements. And tachypnea is actually one of the earliest signs of patient deterioration, which is why, again, we count respirations and we don't just guess or chart what the person before us documented. Tachycardia occurs as the body tries to compensate for hypovolemia and all that vasodilation. The patient may have a fever because they're fighting an invading pathogen, or hypothermia, have a lower than expected body temperature. The extremities are cool and they have delayed capillary refill. When you feel the pulse, it's thready. When you check urine output, it's very low, or maybe they are not having any urine output. And then another key sign is hypotension that is refractory to fluid resuscitation. And that is basically what makes septic shock stand apart from severe sepsis. With severe sepsis, the patient is hypotensive. If we give them fluid and it doesn't improve their blood pressure, now they're considered in septic shock. And again, you could also meet criteria for septic shock simply by having a lactate level above 4. And then non-invasive hemodynamic monitoring for someone in septic shock would show reduced cardiac index, reduced cardiac output, and decreased SVR. So now let's talk about how septic shock is treated. And ideally, again, we really want to identify sepsis and intervene before the patient goes into shock. In some cases, patients progress to septic shock even with that early recognition, but we want to get them the best possible chance they can have. So recognizing it early is absolutely key. And then in other cases, patients don't even seek medical care until they're very, very, very sick. I can't tell you how many times working in the ICU, working now in the recovery room, that will have a patient who is in septic shock and they just got to the hospital that day. They came in very ill, family member brought them in, and now we're chasing our tail trying to get this patient to turn around. And again, the mortality rate is very high. So the initial treatment for someone with sepsis or septic shock is to draw that lactate level, obtain blood cultures, initiate antibiotics, and give a weight-based fluid bolus. And all of this must happen very quickly in order for the patient to have their best possible chance. Every hour that antibiotics are delayed increases mortality by 8%. So in a lot of hospitals, the goal from the time sepsis is recognized to the time antibiotics are infusing, the goal is to get that done in 1 hour. And that takes a lot of people doing a lot of things in a very coordinated and efficient way to make that happen. So if the patient remains hypotensive after we give this weight-based fluid bolus, newer guidelines recommend something called a dynamic assessment of fluid responsiveness test. That's a dynamic assessment of fluid responsiveness test. And this test helps the MD determine if the patient's hemodynamics would respond favorably to more fluids, or if the patient requires vasopressors instead. The reason we don't just keep giving fluids to someone who's hypotensive after the initial fluid bolus is 2 reasons. First of all, we've learned that only about 50% of patients are actually going to benefit from additional fluids. And if we keep giving fluids to someone who doesn't need it or for whom it is not beneficial, we're actually doing more harm than good, and it increases patient mortality. So instead, we do this dynamic assessment of fluid responsiveness test to measure their stroke volume index, and this helps us determine if fluids are going to help or if vasopressors are more beneficial. So let's talk very briefly about performing this dynamic assessment. So the very first thing that you do is you want to get a baseline of their stroke volume index. And if you haven't taken an advanced med surg class yet or worked in critical care, don't get too caught up in thinking, oh, I don't know what stroke volume index is. It has to do with stroke volume, okay? So you're going to get a 3-minute baseline of the patient's stroke volume index. And then give fluid very quickly, either with a small bolus, usually 250 mils, sometimes 500 mils, usually though I think 250 mils, or something called a passive leg raise. Then you observe the patient's stroke volume index. And if that index increases by 10% or more, what this means is the patient is fluid responsive and would benefit from more fluids. If the stroke volume index does not increase by 10% or more, the patient is not fluid responsive, and the MD at that time will likely order a vasopressor like norepinephrine. Now, does this mean if your patient's not fluid responsive right now, that they won't be fluid responsive later? No. That's why this is called a dynamic assessment. Patients' physiology, their hemodynamics are constantly in flux. So this test should be repeated at regular intervals to identify changes in your patient's condition. So the treatments for sepsis and septic shock are always going to be, of course, based on what the physician orders, but there are guidelines out there that are widely utilized to help guide the care of these patients. And you will usually hear this group of interventions referred to as the sepsis bundle. A bundle is simply a group of interventions and assessments that, when performed together, have been shown to improve patient outcomes. So what is in the sepsis bundle? So within 3 hours, preferably even faster, but within 3 hours, the bundle items are to get that lactate, to get blood cultures before we start antibiotics, get the antibiotics going, and give a weight-based fluid bolus of 30 mils per kilogram. And the evidence shows that lactated ringers is the best and preferred and most beneficial fluid for patients in septic shock. So again, within 3 hours, but hopefully as fast as possible, get a lactate, get blood cultures before antibiotics are started, get those antibiotics going, and give a weight-based fluid bolus of 30 mils per kilogram. And then in hours 4 to 6, we're going to repeat a lactate level if the initial level was above 2. So we'll get a repeat lactate level. And then we'll perform a volume status exam, which could be that dynamic test for fluid responsiveness, like I just described, or the patient's physician can do a tissue perfusion assessment, a physical assessment that looks at their tissue perfusion. And then if the patient is remaining hypotensive after they've received their weight-based fluids, we add vasopressors. Now, ideally, what we're doing is we're going off the dynamic assessment to tell us if the patient needs more fluids or if they need vasopressors. And that is essentially your sepsis bundle. All the things that you're going to be doing for your patient with sepsis or septic shock. So I know you like to talk about problems and solutions. How does that look when we look at this from a problem solution standpoint? So one problem with septic shock is hypotension due to hypovolemia and vasodilation. So what is the solution? The solution is that weight-based fluid bolus of 30 mils per kilogram. That's going to increase circulating volume, increase preload, and improve cardiac output. And again, the preferred solution for that is lactated ringers. And the reason for this is because it decreases the risk of developing hyperchloremic acidosis, which can occur with large volumes of normal sodium, 0.9% sodium chloride, or normal saline. So for hypotension due to hypovolemia and vasodilation, we're giving weight-based fluids. If the patient has this problem where they are hypotensive, after that fluid is given, the solution is to perform a dynamic assessment to determine fluid responsiveness. And if they're fluid responsive, more fluids may be beneficial. If they're not fluid responsive, vasopressors are utilized to cause vasoconstriction and increase blood pressure. And then another big problem with sepsis is the overwhelming inflammatory response to infection. The solution is quick administration of antibiotics. And whenever possible, removal of the infection source. We call this source control. If the patient has a Foley catheter that has led to them having a urinary tract infection, we get that Foley catheter out. If the patient has a wound that has an abscess and they're infected in that wound or in that abscess, they get surgical incision and drainage and debridement of that wound. We want source control. So let's do your TLDR for septic shock. Here's your quick summary. Septic shock occurs due to the body's dysregulated and overwhelming response to infection. Patients in septic shock are hypotensive even after fluids are administered and lactate is elevated. That's what's going to separate septic shock from severe sepsis. They remain hypotensive even after fluids are administered. Key labs include a lactate level and blood cultures, and primary treatments are antibiotics, fluids, and vasopressors such as norepinephrine. Okay, I know we have talked about a lot. I have been talking for almost an hour about distributive shock. So let's do a quick pod quiz to go over just the highlights so that you can differentiate between the three types of distributive shock. Okay, are you ready? So I'm going to ask a question, pause for a little bit to give you time to answer, and then tell you the answer. I call this a pod quiz, and I have a whole private podcast called Study Sesh where we just do tons and tons and tons of these pod quizzes. So if you like it, you want to check out Study Sesh. Okay, so what is the base cause for anaphylactic shock? The base cause or initial cause for anaphylactic shock is an allergic reaction. What is the cause or the initial reason that someone would have neurogenic shock? Spinal cord injury. Very good. And then what about septic shock? What is the underlying cause? Infection. Very good. So anaphylactic is allergic reaction. Neurogenic is spinal cord injury. Septic is infection. Very good. Okay, which type of shock involves hypotension, bradycardia, and hypothermia? That is neurogenic shock. Which type involves hypotension and multiple organ dysfunction syndrome? That is septic shock. And which type involves airway obstruction and hypotension? That is anaphylactic shock. Very good. In anaphylactic shock, is vasodilation present? Yes. What about in neurogenic shock? Yes. And what about in septic shock? Yes, very good. Okay, let's talk about capillary permeability. Is capillary permeability present in anaphylactic shock? Yes, it is. How about in neurogenic shock? No, there's no capillary permeability in neurogenic shock. How about in septic shock? Yes. Okay, I'm going to tell you the key medications used, and you tell me which type of shock I'm talking about. Ready? Antibiotics, fluids, and vasopressors. What kind of shock is that? That is septic shock. Antibiotics, fluids, and vasopressors. Very good. How about epinephrine, fluids, dopamine, and diphenhydramine? We're going to use those drugs in anaphylactic shock. And then what about fluids, vasopressors, and atropine? We'll be using those in our patient with neurogenic shock. All righty, how long have we been talking? 58 minutes, my goodness. So yes, this was a big, beefy episode. I'm so happy to bring this to you, to be part of the PodCrawl with other nursing podcasters for Nurses Week and increase awareness about different types of shock. I hopefully will have links to put in the episode notes so that you can go check out these other episodes. I listed them at the beginning and they're listed in the episode notes just in case you didn't catch that earlier. And maybe you'll just find another nursing podcast that you really love. So speaking of love, if you are subscribed to the show or following the show, then of course you get all the episodes automatically showing up for you every Thursday. And then of course, when I have a bonus episode as well. So next Thursday, I want you to come back and listen to the episode on hyperkalemia. So we'll be talking about hyperkalemia, which is an elevated potassium level. So I'll see you back here next week for that. Bye for now. This podcast is brought to you by Straight A Nursing, a proud member of the Airwave Media Network. For more educational podcasts, check out airwavemedia.com. And for more nursing-related content, go to straightanursingstudent.com.
Have you ever wished that you had a direct line to your pediatrician to ask all the questions that constantly crop up while parenting? We sure have. That's why we launched the Bites of Health podcast. Every morning, we'll answer a commonly asked pediatric question in 5 minutes or less. You can tune in while you're making your second cup of coffee or from the school drop-off line. So be sure to tune in to Bites of Health, streaming now.